my name is Today my topic of presentation is intermediate uveitis. What is the uveitis? Uveitis is the inflammation of the uveal tract. We divide the uveitis on an anatomical classification: anterior, intermediate, posterior, and panuveitis. In anterior uveitis, there is iritis, anterior cyclitis, and iridocyclitis, inflammation of iris, anterior ciliary body, and iridocyclitis, inflammation of both. In intermediate uveitis includes pars planitis, posterior cyclitis, and hylitis. Pars planitis is the structure of the ciliary body which inflames, and posterior cyclitis, posterior part of the ciliary body, and hylitis means the inflammation of the vitreous. Posterior includes choroiditis, chorioretinitis, and neuroretinitis. And in panuveitis, whole of the uveal tissue of eye is involved. In this picture, you can identify, this is showing picture of anterior uveitis, intermediate portion of intermediate uveitis, and the posterior uveitis. And in panuveitis, whole of the uveal tissue is involved and inflamed. This shows the picture of the anatomical picture of the eye. You can appreciate that this is pars placata and this is pars plana. This is a portion of the ciliary body. And in this intermediate uveitis, this pars planitis means this portion is inflamed. Pars plana is, what is the pars plana? It is a flat extension from the posterior aspect of the ciliary process to the ora serrata. Its length is about 3.5 to 4 millimeter, and it is 3 millimeter from the limbus. If you appreciate, this is pars placata, which having a finger, pars placata is having a finger-like nodules, and this is pars plana, which is behind this. And in this area is called pars plana. In intermediate uveitis, pars planitis and posterior cyclitis and hylitis is included. The term pars planitis should only be used, that is a subset of intermediate uveitis, where there is a findings of snowballs, snow banking formation, and there is absence of any associated infection or systemic disease. Demography of intermediate uveitis, it's 1 in 15,000, and percentages of intermediate uveitis in the cases of uveitis, it's 8 to 22%, and average age is 22 to 28 years, and it's more 70 to 90% it's bilateral. International Uveitis Study Group suggested that the term intermediate uveitis denote an idiopathic inflammatory syndrome mainly involving the vitreous, ciliary body, and peripheral retina with minimal or no anterior segment or chorioretinal signs. Intermediate uveitis is not hereditary, though it has been observed in the families. Patients who are HLA-DR15 positive have intermediate uveitis. और ऐसी डिजीज है जिसमें HLA-DR15 डिसऑर्डर्स होते हैं, लाइक मल्टीपल स्क्लेरोसिस, ऑप्टिक न्यूराइटिस एंड नार्कोलेप्सी. ऐसे पेशेंट्स भी प्रेजेंट करते हैं विद इंटरमीडिएट uveitis. Pathogenesis, exact theory yet to be known, may be initiated by an unknown antigen leading to clinical pictures of vasculitis and vitreous cells. Antigen may be infectious, like in the Lyme disease, syphilis, or tuberculosis, or it can be autoimmune, like multiple sclerosis and sarcoidosis. Type 2 collagen normally present होती है in the vitreous. Sometimes it acts as a autoantigen in some patients. Intermediate uveitis seems to be a T-cell mediated disease. Lymphocytic infiltrates of the retinal venules cause vasculitis. T-cells predominantly होते हैं about 95%, while the macrophages are the second most common cells. HLA-DR most significant occurred in the 67 to 72% of patients. Now we discuss the clinical features. Symptoms are floaters, mild blurring of the vision, mild photophobia, pain and redness is less common. Now for the signs, to examine the patient, you can see the mild congestion of the conjunctiva. Anterior chamber may show some signs or may not. May show the cells and the flares or KPs, and the posterior synecdoche, which are mostly present inferiorly. You can appreciate the anterior chamber cells. These white particles are anterior chamber cells. It is in front of the iris. Signs: the vitritis is the hallmark of intermediate uveitis, and we can grade from trace to 4 plus the vitreous case. In this picture, you can observe if these cells are behind the lens. This is vitritis because these are behind the lens in the vitreous cavity. Now, scoring. If you see the clear picture of fundus, then it's the 0. And if this little haze, then you can label at trace. And if there is a posterior pole disc and vessels are visible, then we can grade it as +1. And if only disc is visible, +2. And if there is moderate haze, then 3. Or if there is no visibility, then we can label it as 4 plus. This is the classification of the vitreous haze. Now on funduscopy, there is a characteristic mobile globular yellow-white snowball seen in the inferior portion of the retina. These white balls are, I have read somewhere कि इसको ant eggs भी कहते हैं, like it's like the ant eggs. और ये it's mobile होता है, it's not attached to the retina. Inflammatory exudates accumulates over the pars plana to form the snow banking. It's a hallmark of the pars planitis और ये बहुत periphery में जाकर आपको inferiorly नजर आती है. Collagen band over the pars plana. It is periretinal, peripheral and mostly present inferiorly. This white band, ये इसको मैंने क्या यहाँ पे दिया हुआ है. This is a snow banking. Peripheral is inflammatory. These are of the peripheral veins in the vicinity of exudate. There is a white sheathing that shows the peripheral around the vessels. The vitreous show degenerative changes with fiber-like cylindrical condensation. You can appreciate the white cylindrical condensation of the vitreous. There is also PVD, that the posterior vitreous detachment is very common. In this picture, this shows the posterior vitreous detached, सारा vitreous detached हो गया from the retina, and it also causes floaters and the wise ring. This circular thing is wise ring. Retinal changes include toxicity or in the vessels, sheathing, and new vessels elsewhere and new vessels as the disc. ये जो fluffy vessels हैं, जो यहाँ पे ये new vessel of the elsewhere है and new vessel at the disc. Retinal detachment can be rheumatogenic, tractional or exudative. Cystoid macular edema. Half of the patient is having the cystoid macular edema and is most important cause of the impaired vision. And we can see this on the OCT. Disc swelling, macular epiretinal membrane. The cataract and glaucoma of the two reason because of inflammation, and the second reason is use of steroid for the treatment of the uveitis. Mostly the cataract is posterior subcapsular, which is 50 to 50%. Now differential diagnosis, there are two, we can categorize into two: infection or immune. In infection there is Lyme disease, syphilis and tuberculosis, while in immune में idiopathic is 70%, there is no reason for it. And the sarcoidosis 22.2% and multiple sclerosis of 8%. Now we discuss the differential diagnosis number 1. Lyme disease, it's because of the tick, इसमें जो signs हैं, fever, headache, fatigue, irregular heartbeat and dizziness, often associated with anterior uveitis also, and serology performed in the patient from the endemic areas. Syphilis में treponema and the cardiolipin antibody test करते हैं. It's a sexually transmitted disease. So आपने इसमें history भी patient की लेनी अगर आपके पास intermediate uveitis का patient आता है. Tuberculosis symptoms में patient having a respiratory symptoms, fever, fatigue, weight loss. We perform chest X-ray, tuberculin test, and आजकल जो gold test of TB है, blood test जिसको quantiferon test भी कहते हैं, ये करते हैं. Especially अगर आपको suspicion है कि patient may be having a TB, तो before start of the systemic steroid you should perform the test for the tuberculosis. Next is sarcoidosis. ये भी systemic disease with intermediate uveitis associated with granulomatous anterior uveitis. We perform for this, we perform the serum ACE, the angiotensin converting enzyme test, and we do the chest X-ray. 90% of patients present with lung symptoms. Multiple sclerosis, इसके जो पेशेंट्स होंगे वो प्रेजेंट करेंगे विद द न्यूरोलॉजिकल सिम्टम्स, फटीग के साथ एंड numbness, tingling, weakness or walking difficulty के साथ, and mostly the age group is 20 to 50 years of age, or it's more common in twice common in female as compared to male. And there is also acute anterior uveitis, which is granulomatous. We need cranial MRI for the diagnosis. Others are Fuchs uveitis syndrome, इसमें heterochromia होगा, intraocular lymphoma, especially अगर आपका older patient है जो intermediate uveitis के साथ present करता है, तो do look for interocular any tumors. Toxogranuloma में patient may be exposed to cats and dogs, और peripheral granuloma भी होगा. Whipple disease में history में joint और gut की involvement patient बताएगा, bacterial infection. अगर endogenous candida endophthalmitis होता IV drug abusers में, and toxoplasmosis. So, end story ये है कि diagnosis is based on the clinical findings first, and then in history focus on the duration, number of the recurrence, and especially the systemic features for the diagnosis. Investigations, we have already discussed some investigations. Other we can do FFA, reduction of the cystoid macular edema. We can go for LCT macula. We can do body scan if there is exudate and detritus. We can go for CBC, ESR, and C-reactive protein, especially to see the systemic inflammation, and in some cases we do vitreous tract also. For treatment, topical steroids, like topical steroids is not having a posterior absorption, so it's not इतना कोई फायदा नहीं होता इनका. लेकिन ये है कि हम इससे ये आइडेंटिफाई कर सकते हैं कि पेशेंट स्टीरॉयड रिस्पॉन्डर तो नहीं है. अगर आप टॉपिकल स्टार्ट करें पेशेंट हैविंग IOP रेज, तो you label that patient as a steroid responder. Regional steroid injections, posterior subtenon, we use triamcinolone 40 mg, 0.75 to 1 ml, 4 to 6 times with interval. We can do 4 to 6 injections with interval of 2 to 4 weeks, and especially IOP monitoring is very important. We can go for non-steroid anti-inflammatory drugs, naproxen 500 mg twice daily. In resistant cases, we can go for cryotherapy, double freeze thaw. इसमें आप पार्ट्स प्लान पे जाकर आप 3 मिनट्स के लिए फ्रीज करते हैं, एंड फिर 5 मिनट्स के लिए आप इसको थॉ करते हैं, जो डिफॉस करते हैं, फिर दोबारा उसको 3 मिनट्स के लिए फ्रीज करते हैं. और इसमें ये वो उन केसेस में हम वी यूज जहाँ पर हमें रेजिस्टेंट किस्म के केसेस होते हैं, और बट इट इज मोर अप्रोप्रिएट बिफोर द सिस्टेमिक स्टेरॉइड, and because it's associated with the transient increase of the vitritis. But cryotherapy have lots of side effects like retinal detachment, cataract. It can cause vitreous hemorrhage, anterior chamber hemorrhage, epiretinal membrane formation, and hypotony. So we can go for peripheral retinal laser, or it is less dangerous than the cryotherapy. And it's we do the adjacent to the snow banking, and ischemic areas on FFA we do the peripheral retinal laser. Intraocular steroids भी दे सकते हैं पेशेंट्स को, intravitreal triamcinolone और slow releasing implant Olodex. We can go for systemic steroids. Some doctors go for systemic steroids directly. कुछ जो है वो immunosuppressive agents की तरफ चले जाते हैं, लेकिन systemic steroids दे सकते हैं, पर उससे पहले उसकी कॉन्ट्राइंडिकेशन जरूर पेशेंट से पूछें. मोडालिटी इट्स प्रेफर्ड ओवर रीजनल स्टीरॉइड्स. 1 to 2 मिलीग्राम पर kg पर डे प्रेडनिसोन दिया जाता है, टेपर्ड स्लोली ओवर द मंथ्स अकॉर्डिंग टू द रिस्पॉन्स. immunosuppressive agents the mycophenolate, methotrexate, tacrolimus, or cyclosporin we can use. Some other modalities like interferon beta in MS-rated interferon uveitis, anti-TNF infliximab भी दिया जाता है. ये cytokines हैं interferon. We can go for parts surgical option too, parts plan and vitrectomy. It's reducing inflammation and also reduce the recurrence. It's indicated in the patient having a tractional retinal detachment, having epiretinal membrane, or refractory CMO, vitreous hemorrhage and opacity, and new vessels, peripheral new vessels. Cataract and glaucoma प्रोसीजर से उसको ट्रीटमेंट की ज़रूरत होती है उसको करते हैं. थैंक यू.
So the patient of interview, there is only one word, caseation. So in tuberculosis, the granuloma has central caseation, while in sarcoidosis there is no central caseation. So you will be asked these questions in the exam. So remember these. So whenever you discuss differential diagnosis, discuss the most common conditions which are present in our society. So among this list, I will place the tuberculosis number 1. In United States, if we are discussing the differential diagnosis, we will keep Lyme disease and the sarcoidosis. Right. So always start with the most common condition, and in this case, it is tuberculosis. It is very important, as I emphasized already yesterday, that we start with the infectious diseases, because if you will not rule out infections, the uveitis will not respond to steroids. You have to give additional anti-infective like anti-tuberculosis treatment or for the Lyme disease. Then the uveitis will heal. Otherwise, it will become chronic and lead to decrease in the VM. Okay, cystoid macular edema. What is the? In which case will you give a periocular injection, and in which case will you give oral steroids? How you make a decision that to give periocular or intravitreal or systemic steroids? Good. So in bilateral cases you will go for oral, or if the disease is very severe, then you will start with the oral. But if the disease is unilateral, we can go for periocular or intravitreal. And what is the medicine in the Ozurdex? Dexamethasone. And intravitreal, we give triamcinolone. So what is the dose? What is the amount of drug in the vial? 40 milligram. 40 milligram in 1 ml. So if you take 0.1 ml, it will be 4 milligram. That you can inject intravitreally. And if you want to give periocular, posterior septinol, you will give 1 ml, 40 milligram. So any other drug that can be used as posterior septinol? Methylprednisolone. It comes with the name of dapomedrone, so you can also give. The only problem is that you have to monitor the intraocular pressure in intravitreal as well as the periocular steroids. Intraocular pressure can rise, and in the cataract. So you keep on watching for these complications. You said that you will do FFA for macular edema, CMO. Yes. So now, can you modify this statement? For CMO, the best investigation is OCT. So FFA used to be the best investigation, but now, because if it is non-invasive, there are no chances of any complications. FFA can result in syncope and can be a fatal investigation, can produce adverse side effects. And so, any comment? Those who are appearing in the exam, they should always have a comment or a question. That is compulsory. You have to participate in the discussion, but try to express the name.
So, किस